All right, let's look at some resistance to airflow and other air physiology stuff that goes inside the lungs. So we'll start with bronchial dilation versus bronchial constriction. All right, bronchial dilation is where there is an opening in the diameter of the tubes in your lungs, so the bronchioles, and bronchial constriction is where the diameter decreases. Okay, epinephrine and norepinephrine, so these are sympathetic, these are part of the sympathetic nervous system. They will stimulate bronchial dilation, which as a result increases airflow. Histamines and the parasympathetic nervous system, which is operated by acetylcholine neurotransmitter. Cold air and chemical irritants are some factors that can stimulate bronchial constriction. Okay, let's actually draw that out. Okay, in this diagram, you are seeing that this tube right here is nice and open. Okay, so that would be an example of bronchial dilation. And then over here on the green side is an example of bronchial constriction. Now, in this case, bronchial constriction is done by a disorder, so an asthmatic lung. So in other words, inflammation is creating a narrow lumen. Okay, so the opening, when you look down the barrel of a tube, you are looking at the lumen. Okay, so nice and open lumen in the normal lung and a more narrowed lumen in the asthmatic lung. All right, under normal circumstances, we're going to have a bronchial tube that is open. So bronchial dilation, and then we will have a bronchial tube that is more narrow. So this is bronchial constriction or relaxed. Okay, it depends on the author and it depends on what we are talking about. So in this case, everything is normal. There's no disorders, there's no asthma, there's no COPD, no emphysema, nothing like that. Simply bronchial dilation and bronchial constriction or a relaxed state. So in other words, if you are in bronchial dilation and then all of a sudden the tubes relax, well, it's going to go back to, it has to constrict or relax to go back to a smaller diameter. Now, why would you be in bronchial dilation? Okay, well, one answer is exercise. Okay, when you exercise, you are putting yourself in sympathetics. And sympathetics, the reason why tissue and your organs and everything, your heart and all the things inside of us, the reason why they know to be in sympathetics is because of epinephrine, norepinephrine. Okay, these are neurotransmitters, and when epinephrine, norepinephrine hits tissue, it is going to tell tissue to do something in the fight or flight category, the sympathetics. So if you are running, which is a form of exercise, obviously your heart rate's going to go up, breathing is going to go up, the lungs will bronchial dilate, you'll have better gas exchange. So when we exercise, we are actually putting ourselves in a sympathetic stimulation, which is actually a good thing. Now, Sympathetics are known as fight or flight or the stress system. And you don't want to be in sympathetics just because of, you're pissed off all the time, angry, bitter, whatever, all the different human emotions that people have, all this stress, all this anxiety. Being in sympathetics in those circumstances all the time is not good. Okay, those actually have adverse health consequences. But in moments of exercise, being in sympathetics is fine. In fact, it's good for the body. Okay, if you are bronchial relaxed or bronchial constriction, this is more of a parasympathetic. Okay, more of a parasympathetic stimulation. Now, the fun way of saying this is rest and digest. And the way your body knows to be in parasympathetics is because of acetylcholine. Okay, acetylcholine is a neurotransmitter, and when acetylcholine hits tissue, it tells it to be relaxed. So, relaxed breathing, relaxed bronchioles, relaxed heart rate, digestion does great in parasympathetics. Sleep is done well in parasympathetics. All right, if there is a medical condition, okay, so abnormal bronchial constriction. Okay, so we went from this nice open tube to a closed tube, so bronchial constriction, because of asthma or some other condition, and you take an inhaler, what you're taking is a sympathetic medication. So it's actually called sympathomimetic, like albuterol. And when a sympathetic medication binds to the receptors, it's going to allow for bronchial dilation. Okay, so let's talk about that for a second. We have receptors. All right, so here's our tubes. And there are receptors on our tubes. And we have alpha and beta receptors. Okay, when epinephrine, norepinephrine are released, it is going to bind to a receptor. Okay, so if epinephrine, norepinephrine is released, they are going to bind to a receptor. All right, if it is an alpha receptor, it is going to cause constriction. If it is a beta receptor, it is going to cause dilation. Okay, so the bronchioles will have an alpha receptor, which means when epinephrine, norepinephrine bind, it can cause constriction. So from a medication perspective, you would want to block the receptor. Okay, the lung field is mostly, or the bronchioles are mostly beta 2 receptors, which means when epinephrine, norepinephrine bind to a beta receptor, it is going to cause bronchial dilation. Okay, so on a side note, with these receptors, you either want something to bind to the receptor or something to block the receptor. Okay, so from a medication perspective, it depends on the therapy that the person needs. Sometimes these receptors are the wrong chemical, if you will, is binding to the receptor, so they'll give a blocker. All right, so like for example, a beta blocker, or something that will actually block the receptor, and that can also allow for the tubes to relax. Okay, so when you take albuterol, which is a sympathomimetic drug, and the albuterol binds to a beta receptor, it's going to allow for bronchial dilation. Okay, pulmonary compliance. So the word compliance is the ability of tissue to expand. All right, so a balloon is a good analogy. So we have a deflated balloon, and the skin of the balloon has very good compliance. So if we force water or air into the balloon, you're going to get this pretty big expansion, right? So that means that the balloon skin has a high compliance, which means it has the ability to expand. So the lungs, so pulmonary compliance means that the lungs have the ability to expand, which will help increase the volume. Now, sometimes people have a surfactant problem, and we talked about surfactant on another slide or another lecture, but the surfactant, which is an agent that disrupts the hydrogen bonds of water and reduces surface tension. In our lungs, we have the pulmonary surfactant, and it has proteins and basically fats that make up, so phospholipids that make up the surfactant. So as the small airways deflate, the surfactants are squeezed closer together, and if the air spaces were covered with film of water only, they would continue to collapse. But because of the presence of the physical structure of the surfactant, this resists that compression. So the alveoli, which are these hollow balls, if you will, are not going to completely collapse. So the surfactant helps them resist the collapsing. Deep breathing spreads the pulmonary surfactant, so this is important. Deep breathing spreads the pulmonary surfactant throughout the small airways. So this is good whether you are in surgery or recovery or not. So if you're healthy, deep breathing is so good for the lungs and good for the body, good for gas exchange, good for the surfactant, good for relaxing and calming. And all those things are applied to people post-op to get that surfactant, to spread it up the alveolar ducts and into the small bronchioles. Okay, premature infants can lack surfactant, so they have a surfactant deficiency, and so they can have difficulty breathing. That can result in infant respiratory distress syndrome, but this can be treated by administering an artificial surfactant. This graph, this can measure a person's respiratory volume and capacities. Okay, bear with me on the numbers. Okay, so try to pay attention to this. We have this area here. Okay, it's kind of a yellowish area, And this is known as tidal volume. All right, so right in here, this is all tidal volume, which is about 500 milliliters. Okay, so over here, we're measuring this in milliliters. Here's 0 all the way up to 6,000. And most people live in the tidal volume area, which means when you're just doing regular breathing, you're only doing about 500 milliliters when you breathe in and you breathe out. Okay, so that's tidal volume. Now, your theoretical, and I'll explain what I mean by theoretical, max possible inspiration is 6,000 mils. Okay, so if you were able to go max, and not everybody can open everything up because it depends on your training and how good you are at deep breathing and all that stuff. But if you could get about 6,000 mils you can tap into that, okay? And keeping in mind that most people live in that tidal volume of 500 mils. Okay, if you were to just do, let's say, regular max inhale, that's called the inspiratory reserve volume. We are going to go from about 2,500 up to 6,000, okay? Or more specifically, maybe around 3,000 to 6,000. So you're going to increase your inspiratory reserve volume by about 3,000 mils. Okay, if you exhale, you're going to tap into what's called expiratory reserve volume. Okay, which is about, roughly about 1,600 mils. And if you could do the theoretical max exhale, so max voluntary expiration of residual volume, then you would actually get all your mils to 0. Now, what that means is you would have to breathe out so hard that you collapse all the alveoli and the bronchial tubes. Okay, so nobody can do that. So that's why I mentioned theoretical. Okay, so in other words, when you do exhale, when you exhale as far as you can, all right, you're going to go from your tidal volume and you're going to go down to the expiratory reserve volume. And that's everyone's normal. If you could keep going and tap into the residual volume, then you would collapse all of your alveoli tubes, the alveoli and the bronchial tubes. Okay, so now this zone from, let's say, normal max exhale to max inhale, okay, they call the vital capacity, right? So that zone or area is called vital capacity, and that's around 4,500 mils. And then if you could tap into absolutely everything, there's your total lung capacity of 6,000 mils. Now, the way that we measure this is with a spirometer. Okay, so a person can breathe into a machine and the computer is going to pick up where you're at. Okay, so just normal breathing. We'll say this person is at 500 mils, and then the provider says, okay, I want you to take max inhale. See what happens. All right, and maybe for you, that max inhale is only going to take you to around 5,000. And let's do max exhale. And let's say it's going to take you to around 1,900. Okay, so now we have some data. And if you practice deep breathing and some other stuff, maybe we can expand that to 6,000 and down to 1,200. Okay, so these are designed to assess improvement if people have respiratory problems. In my clinic, I do have a spirometer. It's the old school one where instead of digital like this one, when you breathe into it, it's got the styrofoam ball that goes up and these little markers that you physically move with your hand to move it to the lung volume in milliliters. And then we just simply monitor progress as we do deep breathing techniques and nebulizing and some other really good lung treatments.